Glad to talk about what's now the measurement interdisciplinary special interest group. The idea for the meeting group came from Wayne Gordon, who attended and contributed to a pre-conference workshop colleagues and I led in Toronto somewhere around 2007, 2008, I believe. We formed initially what is now known as a networking group, developed bylaws, provided opportunities for others to serve as leaders within ACRM. It really provides an opportunity to focus on what are called outcome measures, but generally measurement issues in general in medical rehabilitation. So much of the clinician measured or patient-reported outcome measures or the instrumented tests that are increasingly used need to demonstrate evidence of reliability, validity, sensitivity to change. And some instruments used in geriatrics, aging research with other disability populations or the general population may be very suitable to the populations we're interested in physical medicine rehabilitation, people with chronic illness, people with physical and other disabilities. Really special care needs to be paid to how well those measures work in the populations we're interested in. It's provided a nice point of contact for people who want to improve, whether it's clinician reported measures, patient reported measures, or instrumented outcomes. I'm pleased that the networking group has grown and now is an ISIG within the current ACRM structure.
Alan Heinemann putting together a team for a grant proposal to NIDRR for an RITC, a Rehabilitation Research Training Center. I had gotten interested in what was known as the black box of rehabilitation, which essentially represented the idea that we get patients, we deliver a variety of services, and we send them home either from inpatient or from outpatient, improved with more physical function, with, for those with say stroke, more cognitive function, participating more in society and what have you. But we really don't know what was going on in those services that were being delivered. And the traditional answer was, well, they got 20 hours of PT and 44 hours of OT and 2 hours of psychology. But that's not describing the services received other than by a very opaque, very general. So my idea was, well, can we open that black box more, get better descriptions of what rehabilitation professionals do hour by hour. I got in contact was contacted by John White in Philadelphia and his colleague Tessa Hart, who had an interest in similar things. And we started working on stuff. At some point, we convinced the board that the organization needed to have a task force or community on classification of the rehab process, which it allowed. It also, and that was when I was not president, but a few years before, went on record that if we developed something that would be on a level with the International Classification of Disability, Function and Health, The ACRM would be the nominal owner of it and steer it and publish it and take responsibility for it, etc.